It's my great pleasure to introduce Dr. Anita Afzali, who is both an MD and a Master of Public Health, so a person who understands health policy and the management of populations and cares for both of those issues. She's a gastroenterologist, as is Dr. Schrawitz, working at Harborview Medical Center. She's the director of the Inflammatory Bowel Disease Program at Harborview and has developed the IBD pediatric to adult transition clinic, very difficult problem of kids who have IBD and who need to transition out of the pediatric care system to the adult system. She received both of her degrees from the University of Washington and completed her internal medicine residency, GI fellowship at the University of Washington, where she works in outcomes research and epidemiology, and she's a great partner for me in the surgery and the medical management of inflammatory bowel disease. Anita?
Thank you so much for the introduction, and I'm very happy to be here with you this evening. So some of the points that I'd like to make sure we discuss today and for you to learn are the basics of inflammatory bowel disease, or IBD. I'd like for you to understand what our immune system is, and then I'd like to review some of our current therapies as well as some of the newer therapies now available or under investigation for the treatment and management of inflammatory bowel disease. So IBD, inflammatory bowel disease, it is a group of chronic diseases that causes inflammation in either the large intestines, which is the colon, and or the small intestines. It entails periods of relapse and remission, meaning sometimes the patients feel well and sometimes not so well. The symptoms vary widely based on disease location as well as the severity of inflammation. Inflammatory bowel disease, IBD, is not irritable bowel syndrome, or IBS. It is not an allergy, and it is not an immune deficiency. But what it is that it's an activation of the immune system in the intestinal tract. And it's chronic, meaning it lasts a long time, sometimes a lifetime. But what's important to remember is that it is treatable. Now, under IBD, there are two main types. There's ulcerative colitis, and then there's Crohn's disease. For ulcerative colitis, as the name implies, the disease is limited to the colon. And so it could start here in just the rectum, or the left side, or the whole colon, meaning pancolonic. And for Crohn's disease, it's a mouth to anus type of disease involvement and location. It's a patchy disease, but don't let the patchiness fool you. Because even though it's a patchy disease, all of the layers of the intestinal tract get affected, and therefore places a patient at risk for development of what's called strictures, which is narrowing of the lumen, or fistulas, which is abnormal connection from one organ to the other. Now, here are some pictures of a normal inside of a small bowel, this furry mucosa that you can see, villi, to a normal pale pink mucosa in the colon with the normal vascular pattern, these little vessels or capillaries that you can see, with normal folds inside the colon called haustra. This is not normal. So again, you have your picture of the normal reference, and then you can see that there's the redness or erythema, and then you have the ulceration and the edema and the swelling, and then really bad swelling ulceration considered severe ulcerative colitis. Now, for Crohn's disease, it's not necessarily a spectrum of the disease, but certain findings that we may see. For example, we can see small ulcerations called aphthiae, or aphtheous ulcers. We can see these punched out larger ulcers, a cookie cutter type of ulcer, to these long linear serpiginous ulcerations, to such severe ulceration and inflammation where the mucosa has this cobblestone pattern, as well as the ulceration that you see being so severe of an inflammation that there's now a stricture or an area of narrowing. Again, there's different types of characteristics we could see in Crohn's disease, and specifically, this is an example of a stricture or an area of narrowing, and an example of a fistula, again, an abnormal connection from one organ to another, and here specifically from the small bowel to the colon. called an enterocolonic fistula. Now, there's no classic typical symptoms for someone who has inflammatory bowel disease, but rather it is all based on disease location. For example, one patient may have severe inflammation, while another patient may have severe abdominal pain. As far as physical exam findings, again, this varies based on where the disease is and what type of inflammatory bowel disease they have. There are extraintestinal manifestations where the inflammation involves the mouth, the skin, the eyes, joints, and liver. And as far as laboratory abnormalities, we see anemia sometimes where there is a reduction in the blood count. And we sometimes see elevation of inflammatory markers. And then based on radiographic imaging, if they have Crohn's disease, we may see fistulas as well as strictures. The impact of inflammatory bowel disease is huge, a very significant impact for our patients. For example, within 3 years from the time of diagnosis, a patient is at risk, 50% risk for being hospitalized. Nearly 90% risk for a Crohn's patient to require surgery during their lifetime. The work disability impact is very significant as well, as you can see, and the emotional impact, anxiety, depression, the impact on the quality of life. Recently, there was a study that put inflammatory bowel disease along with a congestive heart failure, CHF, and a lung disease called COPD as the top 3 medical diseases that are the most in anxiety and depression provoking. So inflammatory bowel disease is characterized by chronic inflammation of the gut. But really, it's a dysregulation of the immune system. So what's our immune system? Well, imagine me walking right in front of you and I trip and I fall. Of course, I'll be embarrassed, but what happens? Well, naturally, our immune system turns on to protect and eradicate any infection at the site of the knee. And once that infection is cleared out or eradicated, then our immune system turns off. Now, the problem with inflammatory bowel disease is that that on-off switch is actually broken. And inflammation is a key aspect of IBD, to the point that there's a large amount of pro-inflammatory proteins and less amount of this off button, so these anti-inflammatory proteins. Now, inflammatory bowel disease, again, Crohn's disease or ulcerative colitis, is the same process with other types of dysregulation of the immune system. For example, the same process as joint disease called rheumatoid arthritis, brain disease called multiple sclerosis, lung disease called different types of asthma, for example, and skin disease such as psoriasis. Same process of a dysregulation of the immune system that affects different organs. Now, we know that for inflammatory bowel disease, the primary component is an inappropriate immune response. But we know that there's other factors that contribute to the actual presentation of inflammatory bowel disease. Genetics, environmental, and the normal gut constituents, as Dr. Sarawicz has mentioned. So let's talk about the genetic component. Is IBD a genetic disease? Well, approximately 10% of patients with inflammatory bowel disease have a positive family history of IBD. There is a 2 to 10% risk for IBD if a first-degree relative is affected. But even among identical twins, so they have the same genetic makeup, even among identical twins, only about 50% of the time are both twins affected by IBD. So it is a genetic component, and it is associated with the genetic association that we've seen, but it's quite complex. Well, then what about the environmental factor? Well, as Dr. Sarawicz mentioned, we are made up of more intestinal bacteria than we are of human cells or skin cells. So understanding the microbiome, as already discussed with you, is very important for us. And there's been recent interest and studies currently under investigation to evaluate the role of the fecal microbiota transplant or stool transplant in restoring a healthy microbiome in inflammatory bowel disease. And the way that we propose that this interaction works with our microbiome is that in row A, you'll see a healthy microbiome. So here is a healthy microbiome that interacts with our genes, and there's no disease, so a healthy person. Row B, you see it's dysbiosis, but here you have an increase of pro-inflammatory bacteria. In row C, we have an increase, or excuse me, a decrease in our anti-inflammatory bacteria. Either state, so an unhealthy microbiome or dysbiosis, interacts with our genes, and then now we see disease. The problem here is that we're not able to really know, there's no good hard evidence for us to know what's considered a healthy microbiome and what's considered an unhealthy microbiome. But we do know that either by direct or indirect effect to our microbiome and alteration to the microbiome by some of these environmental triggers, we do see what leads to ultimately some form of dysbiosis and then ultimately disease onset and presentation of inflammatory bowel disease. Examples, an infection, your non-steroidal anti-inflammatory medications such as your basic ibuprofen. Smoking, we've absolutely seen an association of smoking and Crohn's disease. Stress-related, diet, antibiotics, all of these are potential barriers that alters our microbiome either directly or indirectly and leads to disease presentation. A recent study showed the example of antibiotics, and as you can see here, that the risk of IBD in children rises, especially if they've had more antibiotic courses, 3 times higher risk than someone who's had none. Here in the United States, about 1.5 million Americans suffer from inflammatory bowel disease. There's probably at least 2 or 3 people in this room who are affected by inflammatory bowel disease. The distribution among men and women are equal, and there is an age distribution presenting more in the young adult age to a later onset beyond the age of 60. Working at Harborview Medical Center, I've also seen this rise in non-Caucasian populations and specifically among different races and ethnic groups. So how do we treat inflammatory bowel disease? Well, our medicine cabinet has a number of different treatment therapies and options that we have, from the basic over-the-counter of antidiarrheal medications to antibiotics if there's an infection or an abscess, which is a fluid collection of infection, to medications such as 5-aminosalicylates or mesalamine products, which are used, they're oral tablets, which are used for the treatment of mild to moderate ulcerative colitis, no role in Crohn's disease, to different types of corticosteroids, such as the prednisone or the budesonide, which is oftentimes used in a state of acute inflammation, and lastly to a different class of medications called immune modulators. And these are therapies such as azathioprine or Imuran, 6-mercaptopurine, and methotrexate. These therapies are oral tablets that basically change or regulate the immune system. Now, the problem with these therapies that are currently used, or thus far above all of these in gold, as you can see, the problem is that we have not seen any of these therapies to really change the natural progression of the disease up until recently. Recently, we now have target protein-specific therapies called biologics. And these biologics have absolutely revolutionized the treatment and management of our patients with Crohn's disease and ulcerative colitis. From 1998 and onwards, you can see that we have a number of different what's called anti-TNFs. So as you recall, TNFs are one of those pro-inflammatory proteins. So if we could attack and stop it with an anti-TNF, then we could control disease. And we've been able to demonstrate that we have been able to successfully control disease, reduce hospitalizations, reduce need for surgery, and improve outcomes for our patients with IBD. But what we know is, and as you can see here, one size fits all, except for you, of course. And what this is really reminding us is that for every disease and for every approach of treatment and management, specifically for IBD, we need to find the right patient to start the right treatment at the right time. And this is the art of personalized medicine. So what is the right treatment at the right time? Well, it's easier for me to first give you a description for a similar disease, as I mentioned earlier, with rheumatoid arthritis. Rheumatoid arthritis is easy because you see it and your patients see it, for example. Mild swelling to more and more and more deformities. And they were able to demonstrate that with an anti-TNF agent, starting the therapy early on in these patients, they were actually able to demonstrate that compared to placebo, these therapies were able to change the progression of damage that's happening. So these patients were less likely to progress to this compared to placebo, where it went like this very quickly. Now, we were able to demonstrate a similar finding with our biologics in the use of inflammatory bowel disease, where if we treat our patients early on, they're more likely to have a good response to therapy. And not just a good clinical response, but also on other levels. The difficult part, of course, is the intestines are not like the joints. You don't see it unless you scope or image the intestines to be able to see such a significant drastic finding. And as you can see here, this is that inflammation, that swelling, the ulcerations, those deep ulcerations I described to you earlier, and look what happens. You start the appropriate therapy for the appropriate patient at the appropriate time, and we're able to prevent a potential stricture here. And what we know is that if we don't treat the inflammation early, then this is where the fistulas happen, this is where the strictures happen, and even microperforations or holes in the intestinal tract. And what's important is that most patients, as you can see here from this graph, initially present with inflammation, active inflammation that can be targeted by our treatments, such as the biologics, anti-TNFs, as I mentioned. But what happens is that if we don't treat early, look what happens over a 20-year time frame. Over a 20-year time frame, even though most patients initially had inflammation, now the disease has progressed. About 90% now have penetrating fistulas and stricturing, narrowing type of disease. Again, important to find the right patient, right treatment at the right time. Because if we don't, this is what happens. The risk and need for surgery over time increases. We've been able to demonstrate that. Likewise for ulcerative colitis. If there's active inflammation that's not treated, the risk for a total colectomy, take out the whole colon, increases to about 30% within 20-year time frame. And what we were able to demonstrate, this study very beautifully shows us that since the initiation or introduction of our biologics, and specifically anti-TNFs, with the first one in 1998, you can see that the need for that total colectomy, taking out that whole colon, has declined. Now, what we know is that we have had really good options for treatment, specifically the biologics, as I mentioned. And this biologic was the anti-TNFs I described to you. And here you can see from this picture that we have a number of other options available for potential research that are currently under investigation. I hold different clinical trials for these therapies, and there's other institutions across the state and country who are investigating the potential new clinical trials for new therapies. We call this the IBD drug pipeline, meaning can we potentially try some newer therapies and target this inflammatory cascade, those pro-inflammatory proteins I described, can we target some of these other areas potentially? And also, can we target the gut-specific white blood cells? And the reason this is important is that the gut-specific white blood cells we know is a hallmark of inflammatory bowel disease. We know that an accumulation of these cells in the gut actually causes damage. And so now I'm going to show you a little bit of an animation for you. So let's take a small little slice of the intestines, as you can see here, and we're going to magnify it on a molecular and cellular level. So here you have your mucosa. This is that lining with the villi, for example, or the colon on this side. So above up here, this is your lumen. This is where things enter our gut. This is your submucosa. And these are your the blood vessels, right? So you have different types of cells. This green cell with this long arm is a dendritic cell. These cells, and I'll show you, are T cells, which are one of the cells involved with our immune system. This is a macrophage, a different type of cell. These are some white blood cells that, again, enter through gut-specific in our blood vessels. So what happens when an antigen, so a toxin, a foreign substance, comes into our body? So our immune system is activated. And so now our dendritic cell recognizes the antigen. And now you can see that the dendritic cell is trying to activate the immune response, as I mentioned earlier. So now our T cells come to the area and accumulate more help with more T cells. More T cells get to the other antigens and says, I need to attack you, I need to get rid of you. So it releases those different pro-inflammatory cells and cytokines and proteins. And the T cell says, I need some help from some additional cells. Let me recruit some macrophages. So the macrophages wake up and they get put to work. And then the T cell says, I need more help, and I'm going to bring in some white blood cells. But before I could bring in those white blood cells, I need to release that surge of white blood cells with releasing more of these pro-inflammatory cytokines and proteins. So the white blood cell says, here I am. And it's trying to get to the area to help attack the antigen, that foreign substance. Now the white blood cells each have a zip code that is identified by particular mailboxes. And if those two areas connect, then it enters our gut, hence gut specific. So as you can see, the white blood cell is trying to identify its mailbox. And it finally gets in, it gets through. But the problem, as I mentioned for you with inflammatory bowel disease, is that this process is very dysregulated. So the white blood cells multiply and cause more and more inflammation, and ultimately accumulation of these white blood cells, well, what happens? It actually causes more disease, more damage, the inflammation, as you can see, disease called inflammatory bowel disease. So what happens if we target some of these areas? Again, target-specific therapy, biologic therapy, to try to actually change the progression of our disease. Well, as I mentioned to you, we have the white blood cells. The white blood cells try to enter, they try to identify their mailbox. But what happens if we erase the zip code, or maybe cover it up? Now we don't know where's the mailbox, right? So now it blocks the entrance of this particular white blood cell with this type of coding. We've covered up the zip code, right? And so now it can't enter the site. And this is what happened with research, with our clinical trials. We found Entyvio, or vedolizumab, to be just that. It's an anti-adhesion molecule or treatment. It's a biologic therapy. It's an infusion that our patients receive who can potentially respond very nicely to. Again, the treatment is target-specific protein, and in this case, an anti-adhesion molecule. Well, what about a different attempt? Let's try something else. Well, you may have seen some of the commercials, but we have ustekinumab, or Stelara, which is already FDA approved for psoriasis. The way Stelara or ustekinumab works is, remember that long dendritic cell that initially identifies the antigen? Well, the way it activates the T cells is because it has the right key and lock. And so if we potentially find a therapeutic option at this level, maybe, again, we can have an option for our patients suffering from inflammatory bowel disease. And so if we can prevent that initial attachment, then we prevent also this accumulation of pro-inflammatory proteins and cytokines. So that was exactly how ustekinumab became available for psoriasis, and now currently under investigation, and we have several clinical trials here at Harborview and the University of Washington Medical Center to evaluate this role in inflammatory bowel disease. And then there's another option, and this is an option where it's one of the first biologic therapies, again, target-specific protein that you take orally. Our other therapies have either been an infusion or subcutaneous, where you have to inject. So this became an option where we can make it an oral option, but still be a target-specific protein. And this was an oral SMAD7. So what we know with SMAD7 is that inside the T cell, this is what is activated and chronically releases a large amount of pro-inflammatory cytokines. So what happens if we potentially block SMAD7? Well, if we potentially block SMAD7, such as a therapy currently under investigation called Mongersen, then we potentially are able to now prevent this accumulation of pro-inflammatory cytokines. And we've been able to see that so far, where now we're allowing this TGF receptor to now be an effective inhibitor of the pro-inflammatory cytokines and proteins. So these are some excellent opportunities for research for us in the management and treatment of our inflammatory bowel disease patients. And we hope that over time we'll be able to have more therapies for our patients. And I thank you for your time.
So questions for Dr. Afzali. Please come to the microphone if you can. I was drawn to thinking about the Republican debate over the weekend. I can't, from the analogy of the immune system, but I won't ask you to draw that analogy any further. Questions?
I'll stop it right there.
Inflammatory bowel disease. How many people have a family member or friend who suffers from inflammatory bowel disease? Very common. And you've seen the kinds of effects it has on their lives, on their sense of well-being, on their ability to do so many things. The best patient from a surgical standpoint that we ever see is one who doesn't need surgery. And so it's a great partnership to be able to control this disease and prevent progression to the kind of the disease, the fistulas, the strictures, the obstruction, the infections that sometimes do require surgery. Questions? Another Anita coming down.
Hello, thank you for your talk, both of you. It's been excellent. So what is life like for the person that has this type of disease, for those of us that don't have an exposure to it?
That's an excellent question. So the question is, what is life like for a patient who suffers from inflammatory bowel disease? And life is tough. So I described to you the impact, right? So as far as work disability, time off, hospitalization, risk for surgery. But what about the day-to-day? Well, imagine not knowing if you could leave your house because you don't know where the nearest bathroom will be if you leave that house. Or imagine being in a restaurant and there's already 5 people in line for the closest restroom and you need to be at the very first or front of the line. That unpredictable nature of the disease. And then the pain based on the strictures or the fistulas. The impact of that pain is very significant for our patients. The malabsorption, they have inflammation. I showed you the pictures, right? So the inflammation, that ulceration, the swelling, the thickness, the scarring down of the gut, what happens? Well, as Dr. Strouge described, it's our gut that helps us absorb the basic vitamins and nutrients that we need. So now our patients are malabsorbing, significant amount of weight loss, significant amount of other alterations in their nutritional ability to absorb these basic nutrients and vitamins. So life is tough for our patients. But then what is life like once we control their symptoms? It's beautiful. It's great to see a smile on a patient's face after we've been able to find the right treatment for the right patient at the right time. The art of personalized medicine, finding the therapy that works for the patient, and specifically finding what triggers their inflammatory cascade. And once we're able to find that trigger and treat it appropriately, their symptoms improve, the inflammation decreases, their pain goes away, they're not looking for the nearest bathroom, but now they're running their first half marathon. So the huge drastic difference of the before and after once we are able to manage their symptoms.
There are lots of gastroenterologists, not a lot, but many more than IBD specialists. Could you comment on the value or the capabilities of a gastroenterologist who doesn't focus on this as a specialty versus the specialty focus?
So a specialty-focused gastroenterologist who focuses on inflammatory bowel disease versus a gastroenterologist who doesn't focus on IBD. And I would say that the difference probably it varies depending on institution, location, community setting versus a university setting or academic setting where they are still hearing our talks and reading our papers and lectures. But I would say it's a comfort level, right? It's an experience level. For example, I see hundreds and hundreds and hundreds of patients who suffer from inflammatory bowel disease, and a local gastroenterologist or community gastroenterologist may only see 1 or 2 a year. So it is that comfort level of knowing and being able to identify the right patients who need that right treatment and the right time, right? So the community gastroenterologist doesn't know who that right patient might be and what that right treatment may be, versus someone who's much more experienced and practices clinically in managing inflammatory bowel disease, does our research and our investigations for inflammatory bowel disease. Our comfort level and our experience is drastically different.
And if you don't have IBD, is there a way to catch it? Should people be careful about anything to avoid catching it?
There's no way to catch it, right? So we mentioned the different types of factors. There's already, for some reason, that dysregulation of the immune system. So we don't know how you can catch it unless you're already susceptible to it. But we do know that patients are at risk for it, right? Smoking, yet another reason to stop smoking. We know, for example, that smoking, that environmental toxin, being smoking, and already potentially being susceptible to inflammatory bowel disease, put that together and the risk for Crohn's disease increases dramatically. So there's absolutely ways and things, as I mentioned, the antibiotic use, ways and different factors that we have identified that places you at a higher risk for it, but purely catching it because we're next to someone who has it, it doesn't transfer like that.
And linking to what Chris talked about earlier in the microbiome, protecting the microbiome in terms of antibiotics,
Absolutely.
diet, lifestyle.
Absolutely. So as you saw, protecting the microbiome, again, first and foremost, we need to identify what's the healthy microbiome and what's the unhealthy microbiome. But regardless of that, just protecting whatever state of microbiome that we have, that our gut flora is comprised of, maintaining that is important. Because again, as the studies showed, for example, the use of antibiotics, that altered the microbiome in the children and increased the risk for presenting with inflammatory bowel disease. So if we could protect our patients, one of the best ways, again, emphasizing, don't take antibiotics unless you absolutely need it. Stop smoking. Some of these factors, again, comes into play over and over again.
So people are at risk, perhaps for genetic reasons, but then triggering events like changing the microbiome, antibiotics, diet, smoking, activities, both can set off the disease and modulate the severity of the disease.
Absolutely.
Right? Question?
Yeah. So on your slide with the map, so it showed the worldwide prevalence had increased, but it seemed like there was a band around the equator where it wasn't as strong. Is there any theories to why that is?
That's a great question. So the question is that on the map that showed that the prevalence, meaning the number of cases we're seeing and the incidence, the cases that we're seeing over time, has increased, but near the equator, we haven't seen that much of an increase. And I'll start with saying we have. We're slowly starting to see it even in those areas near the equator. Again, inflammatory bowel disease was initially thought to be more of a northern latitude type of disease, and we've seen the demographics of this disease absolutely change. And over time, I anticipate that the prevalence, the number of cases that we'll see even near the equator, I think will definitely change. Maybe perhaps not as drastic or as much, not be highlighted in red like we saw in the Northern America or Northern European countries, but absolutely over time, I anticipate that we will see that rise. A special interest of mine in research is to study the impact of race and ethnicity with inflammatory bowel disease, and specifically working at Harborview Medical Center, we have a nice cohort to evaluate the trends, and we're seeing that patients from countries that we didn't even think there would be inflammatory bowel disease diagnosed, we're seeing a rise in certain areas of the world.
Great, thank you so much.
Thank you.
Is there any correlation between inflammatory bowel disease and processed foods? Could they have could the increasing consumption of processed foods be part of what we're seeing with the increase in IBD? And if there's an area around the equator that maybe has had less of it, could it be because they eat more fresh fruits and vegetables?
So the question is, can our diet, and specifically processed foods, impact and place one at risk for presenting with inflammatory bowel disease? And specifically, perhaps countries near the equator, as the question earlier was asked, perhaps they're not being exposed to the same amount or the same diet, the processed foods, et cetera, then perhaps that's why we're seeing a decrease in numbers of inflammatory bowel disease in those regions. The answer is, we're not quite sure, but we absolutely know that diet has an impact, being that environmental trigger. Now, the problem in our diet is we don't know what exactly. There's been lots of nutrition studies, for example, that have tried to evaluate different types of diets, from a specific carbohydrate diet to other types of diets, as well as supplements or herbal approaches, turmeric, curcumin, for example. So there's different studies evaluating the impact of diet and nutrients in the presentation of IBD, but we have not been able to clearly identify that direct association of processed foods equals IBD.
Great, thank you.
Thank you so much.